Kingdom, the chair of diabetes and the Ramadan International Alliance. Yes, the floor is yours, Professor Mohamed Hassanien.
Thank you very much, Professor Gamina, for your kind introduction. Thanks for Professor Ines for the invitation, and for our sponsors, Novartis, for extending the invitation to me as well. So I would like to follow with what Professor Ines have mentioned on the clinical trial, and look into 3 short cases on how can we apply these recommendations and the guidelines, as well as the new clinical trials on everyday practice. Whether it's applicable or not, that is what we will see together now. So let's just proceed with the first case scenario. So there are very simple case scenarios. There is nothing difficult or complex in them. These are typically patients that you see every day in your clinical practice. So my first case is a teacher of 55 years of age. He's a male. He has history of hypertension and ischemic heart disease for the last 2 years, ischemic heart disease, hypertension for longer. His EGFR is a bit reduced to 65. His HbA1c is 8%. His body mass index is 28. He's currently on dual therapy of metformin and gliclazide, as well as treatment for the hypertension, ischemic heart disease, and a statin. And let's focus on the glycemic control. Let's not get into other issues. So from a glycemic control point of view, what should we do? So I show you here the algorithm of the AASD, which was published initially in 2018 and got recently updated. And as you can see here, in 2018, they are talking about people with established atherosclerotic cardiovascular disease or chronic kidney disease. If this is the case, then regardless of the HbA1c, we need to consider adding either a GLP-1 receptor agonist with proven benefit or an SGLT2 inhibitor with proven benefit. Which one do you choose? The consensus, if it's more of heart failure or kidney problems, then it's an SGLT2. If it's more of an atherosclerotic problem, then it's a GLP-1. When they updated the recommendations earlier this year, January of this year, they looked into not just the established atherosclerotic cardiovascular disease, but those with very high risk, which in my mind, this is actually disease, because as you can see here, they're talking about people with left ventricular hypertrophy, with coronary or carotid or lower extremity artery stenosis of more than 50%. So there is already an angiogram and been done either on the coronaries or the lower extremities, or some sort of a Doppler that established that there is 50% or more of stenosis. Anyhow, that was the ADA and the ESD recent recommendation and recent update for the recommendations. I personally have the pleasure of being part of the very recently published Emirates Diabetes Society recommendations for the management of type 2 diabetes. And here we have looked into risk categorization. We've looked into the various guidelines that is available, and we've modified them to the local requirements. So someone like our patients that we've just talked about, a 55 years old male with established ischemic heart disease, what we said here is either this or a target organ damage, then they are considered as very high risk. If they don't have an organ damage, but they have diabetes for over 10 years, and they are aged over 50 years, and they have more than two or more risk factors, they are considered also as very high risk. So that would apply to our case. And the recommendation is to start either a GLP-1 or an SGLT2 with benefit, regardless of the HbA1c. So this is an important point. So the HbA1c here is not a factor in the case that I've presented. And then if they fail, we can intensify the treatment, as you all know. But I think we have focused massively on cardiovascular outcome trials, and I think we have to put everything into context. When you look into the cohort of patients of the EMPA-REG or the Canvas program or the DECLARE study, how many of them apply to everyday patients? For EMPA-REG, it's 92% who would not be eligible for EMPA-REG, for empagliflozin treatment. In the Canvas program, it was 80% would not be eligible from the cohort published in the BMJ earlier last year. DECLARE, because it included many people with multiple risk factors, it was considered to be 60% would not be eligible for this. So while a lot of the scientific discussion is talking about the cardiovascular and the renal patients, let's not forget that's not the majority of our patients, at least in the early stages. If you apply the same to the NHANES data of 240 million persons with diabetes in the States, you will look into the cohort of patients that's been taking part into these excellent GLP-1 receptor agonist cardiovascular outcome trials, you will find that they would range from as low as 8% to as high as 22%. So clearly, the vast majority of our patients are not necessarily patients with existing cardiovascular disease or extremely high risk that would necessitate this automatic addition of an SGLT2 or a GLP-1 receptor agonist. I looked into a study that we've published by Professor Ines as a co-author in the Ramadan study, which is on gliclazide MR. And I just want to highlight that of the baseline characteristics of our patients with a mean age of 54, with a mean duration of diabetes of 5.4 years, there was only 6.3% with established cardiovascular disease. There was about 28 to 35% with either dyslipidemia or arterial hypertension. So risk factors are there, but established cardiovascular disease is not necessarily the majority of our patients, and this is something that we need to remember and we put into context. So let me go to the second case, which is more of what we see frequently in our practice. This is a person who's 45 years of age, male, hypertensive, with a BMI of 29, with a normal renal function, and this person is already on a reasonable dose of metformin of 1,500 milligrams. Of course, he's also on the other treatment for his other conditions, such as the antihypertensive and the lipid lowering, considering that the person has hypertension. So when I think of this person risks, I see that his diabetes duration is only 4 years, he's under 50 years of age, he has 2 added risk factors. So when I apply our scheme that we've produced from the Emirates Diabetes Society, that here is the patient under 50 years, under 10 years of diabetes duration, with 2 risk factors, 2 added risk factors that put this person on a moderate risk. He will still be on a moderate risk if his diabetes duration to increase or if his age to increase, but with less risk factors. So this is important to remember. And this is typically the type of patient that you would like to say, okay, I'm already on metformin. What should I use of these classes of drugs? They're all available to me. How do I choose? Well, you need to think of the efficacy of the drug you want to choose, the risk of hypoglycemia, the impact on weight, the cost, and of course, the baseline HbA1c. Because if the baseline HbA1c is above 10, then the recommendation is to go to insulin according to the guidelines. Otherwise, you can think of any of these equally according to the individual case, and all of these parameters, including, of course, cost, is one of the important parameters. Of course, you would intensify the treatment, but you would avoid having two incretin-based therapies together. And then eventually, if the person is not well controlled on triple therapy, then you would intensify the injection or initiate an injection. So clearly, the ADA and AASD are not disputing what we should do, but they are just highlighting, as what Professor Ines in her presentation mentioned. She has mentioned the word 3 months, and this is what we all unfortunately ignore. We don't wait for 3 months, we wait for 3 years to add the second line drug from monotherapy to dual oral therapy. And if they're on dual oral therapy, we wait for 7 years to add the third line. And then eventually, to add insulin, we even stay for a similar time on a person already on triple therapy. So that is something that's been highlighted in the studies that have been published over the last 6-7 years, and we really need to stop this inertia, specifically when we know in some sectors of therapy that our patients might not be available to see frequently in our clinic. You've seen this slide by Professor Ines. I'm not going to repeat it again. All I'm saying is this is what we want to do. We want from very early in the therapy, use whatever weapons you have, lifestyle, education, and the right combination therapy to get your patient in control and remain in control for as long as possible without this yo-yo situation, which is not really helpful. Why is that? Because it does matter. It does matter. When you look into the difference between this person whose HbA1c was in the mid-8s, going down to roughly about 7.5, which many of us would say, it's so good, it's okay, I don't need to have intensive treatment. Well, when you have this sort of okay, this is what you end up with. After 5 years, as been shown in this published by Kunti et al., published 3 years ago, that you talking about higher rates of myocardial infarction, higher rates of stroke, higher rates of heart failure, and higher rates of the composite cardiovascular events. So it does matter, and we should not really have this sort of attitude of it's okay. No, we need to get good control for our patients. Because what we've seen from the VERIFY trial is that the lines separate quickly. What are these lines? This is patients with events. What we're talking here about is macrovascular events. Yes, the hazard ratio was crossing the line. Yes, the p-value was not significant, but I don't think that anybody would be happy with higher numbers of cardiovascular events in their cohort of patients. So really, this is important for us to remember. So I would like to move to my last case, which would apply very much to the discussion that you just had with the verified case, because this is a new diagnosis. This is a 39-year female with type 2 diabetes. She has no history of other comorbidities. Her HbA1c is 8%, BMI is 28, non-smoker, LDL is 110 with a total cholesterol of 165. How should we treat? Well, there is no doubt that metformin needs to be part of that. But as Dr. Ines mentioned, here is the update of the ADA for 2020, where they published their points. And here they're saying the initial combination of the DP4 inhibitor vildagliptin with metformin was shown to provide a lower rate of secondary failure of glycemic control to HbA1c above 53, which is 7, versus metformin alone, or the sequential addition of metformin plus vildagliptin. So it's not just about the molecules, it's about the timing of the molecule. That is really what is quite important. It's quite important for us to remember that it's not just the vilda or metformin or another drug. It is the molecule and the timing of the molecule. That is really quite important for all of us to remember. So that's why they are saying is that we suggest have that discussion. They were not strong enough to say, we recommend changing the guidelines. They did not say that. But they stopped short from saying this by saying, consider it, think about it, discuss it with your patient, because after all, you can gain longer duration of good control. The added years with good control can give the person the confidence. And of course, I agree with Professor Ines, we need to see the impact of this on microvascular complications. Macrovascular complications, we know it might need longer time, but with the microvascular complications, it could be much shorter. But for the treatment here, the number of events, it is not really about whether the person got the second drug or not. It's about the timing. Initially, you combine or you add on when required. And that's the difference between the early combination and the initial monotherapy that required the addition of the drug a bit later. So you see here, there was no failure in 5 years. 60 months, there was no failure on the early combination, while obviously in the other groups, there was a need to intensify and to add therapy as you go. And we've seen this in ADOPT trial. We've seen this before, many years back in 2006 in ADOPT trial, that when you use monotherapy, you will have good control for a number of years, but then gradually, whether this is a glitazone or a metformin or a sulfonylurea, gradually the control will need to be intensified again. So it's a matter of why can't we do something to remain here rather than we end up here and then start to try to get it down again, and whether this is successful or not. So if I were to go back to this case of the early diagnosis, this is a person under the age of 50, newly diagnosed with one added risk factor. This person is a low risk. So what we use for low risk or for moderate risk or even for high risk is any of these. You choose what you think, and what Verify is saying to us, it's not just about the class. I mean, for cardiovascular outcome trial, we say the drug with evidence. We always keep saying the word drug with evidence. So I might as well use this if we are to use the early combination. As per the previous question to Professor Ines, is which one would you use? I would say the one I have is the one with evidence. So all the time, we have to balance things. We have to balance things between the timely and the effective and the stable glycemic control to improve glycemia and prevent complications versus the risk that the drug can have, such as hypoglycemia or weight gain, or maybe it's the impact on other factors as well. So this is really what you need to think of. And I really like the fact that our patients often with the combination therapy don't feel it's two drugs, because the availability of the combination in a single tablet is there. The psychology, and we've heard Frank talking about the psychology for our patients. Certainly we know that the psychology of multiple drugs make people not so happy, but when they see that they are on single tablets, it may improve adherence. And adherence is obviously linked to the HbA1c, which we all are keen on. So my take-home message is really quite simple. Cardiovascular and renal risk quantification is essential for all our patients. And this is important to do and important to follow, and we have good evidence. But this is not the majority of my patients. We need to provide a treatment that is tailored according to the patient profile. The profile could be the comorbidities, could be the risk of hypo, could be the weight, and could be the finances of the individual, as well as many other factors. When we are thinking of all of these points, it's really important to apply evidence-based medicine. The choice of therapy needs to be backed up with evidence. We are sometimes blamed for the physician inertia, and we need to try to overcome this, because this inertia could lead to avoidable morbidity and mortality. Our patients with diabetes, they already have a risk that we want to reduce, and we don't want to increase that risk by our own inertia. Early intensification is an important concept as mentioned by the ADA, that we should consider for many of our patients and discuss with them and see whether this would be the right choice for them or not. After all, the ideal treatment for diabetes, you need to think of all of these parameters. Efficacy should be high. Weight should be either neutral or indeed to help losing weight. Risk of hypo need to be abolished or low. It needs to obviously to address the problems of diabetes, including fasting and postprandial hyperglycemia, need to be simple to administer with a very low profile of side effects, with evidence and with cost effectiveness. I would love that someone would tell me which drug is this. I'm sure you will all try to think if it does exist or not. Thank you all, and I look forward to any questions that you have now. Thank you.